So we often think of data and augmented intelligence as something that's kind of dry or remote or a little bit dorky even, but actually big data can really help with patient outcomes, and it's working with doctors every day already across the world. So we have here two people who are very involved in this space, and so just to dive right in, maybe you can each give me, Paul and Q, an example from your companies of how big data can actually help with medical diagnoses.
Okay.
Sure. So first of all, at OptumLabs, we're an organization that works with the data from Optum, which includes data from United Healthcare and other claims data, as well as Medicare data and electronic health record data. And we have built a number of predictive models for identifying patients who are at risk for various things, which may put them at harm or may lead to costly outcomes, et cetera. And one of those, for example, that I actually developed with that data while I was with Humedica, which is part of Optum One now, was a model that identified patients at risk for hospitalization with congestive heart failure. And that model was able to, when put into use with a process around it, training the people at medical institutions, was able to reduce by 60% the number of hospitalizations year over year for congestive heart failure. It's those kind of simple, straightforward questions that involve just bringing a patient in, evaluating what the issue is as a result of a predictive model, as a result of artificial intelligence, that can lead to improved outcomes.
And tell me why you refer to yourselves as data Sherpas.
Well, OptumLabs was started initially with Mayo Clinic and Optum as a small unit. We're about 65 people or so within this gigantic organization, United Health Group, the largest, first or second largest healthcare organization in the United States, if not the world. This small group now has about 30 partners or so that include places like University of California health systems and AARP and the American Medical Group Association and Health and Human Services, actually, the US government, to bring together organizations that are interested in using that data, all of that data that I talked about, to improve healthcare, to innovate, to do research, and to do translation, to take those research results and put them into use. So our group, our little group, is actually not doing the research. We're not providing services. We're not a for-profit entity within Optum or United. We are helpers. We're data Sherpas. We guide the organizations to, the researchers, to where the best path through the data is, where the crevasses are, and how to get to the peak, and how to get down without harming yourself, let's put it that way. In any case, that's what OptumLabs is about.
And Q, you work, just so for everyone in the audience, you work with Watson of Jeopardy fame, but it actually has a huge medical and health component. So tell us a little bit about how Watson works with doctors and in hospitals.
Yeah, so the way I like to frame it is as a primary care physician, as an internist and pediatrician, was faced with a lot of big data challenges. So if you think about what doctors are facing, and many of us have experienced being with a doctor or being in that setting in a waiting room and having those 15 minutes with that physician and being in that moment where you've got all those questions and all those issues. And doctors similarly have a big challenge in that engagement. They have a big data challenge. They have all the textbooks, the journals, the medical records to keep track of, and all the patients that they have to think about and manage. And so what Watson does is basically translate that big data into insights. And that is a big part of what we're doing at Watson Health. We're 2 years old in terms of looking at this, very focused in healthcare and the role of cognitive in helping healthcare professionals. And now we're very proud. I was just at 2 major scientific conferences at the American Society of Clinical Oncologists. And we're proud to talk about how there's 55 hospital systems across the globe, whether it's India or China or Slovakia or the Netherlands or the US, or Mexico, that doctors are able to use Watson to help with treatment decision support at the point of care, to bring that big data together into an insight to help a physician who's trying to take care of a person with colorectal, with breast cancer. And so we're very proud of that. We're also proud of the clinical evidence that's starting to demonstrate in terms of the role of Watson in being very concordant with what the best oncologists do. And this is a very big part of AI, or we call it augmented intelligence, about supporting physicians. That is an important ethical purpose that we believe that AI is for, that it is to help support those doctors, and it's the doctors who make the decisions. And so we've got up to 96% concordance with the best oncologists in terms of what Watson recommends. And in areas like clinical trials matching, there is a percentage of 78% in terms of reducing the amount of time. If you think about all those medical records and all those clinical trials that exist out there, the ability to match a patient in those 15 minutes with a clinical trial is very challenging. So Watson has the capacity to read all that structured and unstructured data and provide matches that a provider can then engage the patient and discuss. So we're very excited about those.
And when you say, something I thought that was interesting that you mentioned was that it actually reads medical journals and all the studies that I'm sure many of the people in this room are well acquainted with how tedious they are to read sometimes. But it can actually read them, a lot of them, very quickly, right?
Yeah, so what I'd like to say is there are 4 major ways in which Watson helps. And so this is very key. And it understands, reasons, learns, and empowers people. And so part of the understanding the reasoning process is a training process. So we trained Watson to learn and read medical literature and medical records with some of the best experts at Memorial Sloan Kettering. They still continue to train Watson, Mayo Clinic, Cleveland Clinic, and that's a very important part of being able to read that literature, to be trained in that area. And actually, the history of Watson and cognitive in healthcare starts in 2005. We've been very engaged in this new era of cognitive. And so that's important, to have that assistant that supports you as a physician when you're seeing patients, looking through medical records, looking through medical journals. There are 8,000 publications a day that are done. I mean, it's humanly impossible for any person or any group of doctors to keep up to date with that. And so that ability to track all that, all the 26 million studies in PubMed, the 4 million drug patents, all that is part of Watson's corpus.
And something that I thought was interesting about Optum is that OptumLabs, it brings together lots of different data sources. And that's something that I've heard is sort of an issue sometimes for doctors or people in the medical field, is that the data doesn't really talk to each other. And it's hard, even if you have an electronic medical record, it's hard to, as a doctor, to look at, okay, here are all my patients, here's what I can do to help this person who's coming into my office today. Why is it that it's so hard to get these data systems to actually communicate?
Well, doctors are overwhelmed with data. We're not in a time when there's a lack of data. What's the most essential part of the problem is to ask the right question, to figure out what the data are that you need to be able to address that question. And assembling the answer, whether it's through artificial intelligence or a more traditional research study or through cognitive computing or whatever, can actually be not the hardest part about it. The hardest part about it is understanding what the problem is. But the systems currently are not designed, they're designed predominantly to be transactional systems for the purpose of documenting a patient visit. And these are electronic health record systems and many other types of systems, and systems that are oriented towards creating the administrative claim, et cetera. As such, they weren't necessarily designed initially to be data warehouses, although data warehouses have been built on top of them. And although standards exist, those tend to be loose boxes of standards in which you can put a jumble of information. So no matter what you're doing, if you're taking the structured data and the unstructured data, where 70% of the value of an electronic health record exists in the narrative that doctors write, if you're taking that data and trying to standardize and normalize it, it currently is somewhat of a manual process. that can become automated, but requires data forensics and research to understand that when there are 5 different times about when somebody entered a healthcare system, which of those times are the one that you want to choose as the beginning time to be able to measure an end time, and to standardize that across systems. You have to do that for every variable that's involved. But one of the things that's really important is that using artificial intelligence, it's possible to now take those narratives where 70% of the value exists, use a variety of natural language processing techniques, and be able to extract information without going in and formally structuring that information in a way that you can address and ask questions and get answers.
I'm just going to quickly answer. I think it's a lot about trust, and it's a lot about recognizing that health is so much more than health care. It's both. You need both. So I like to reference the statistic that as a physician taking care of patients with diabetes, typically I would spend maybe 2 hours a year face-to-face with them in that clinical setting, one-on-one, at the most. And so there's 8,758 hours where they're outside in the community, where they're outside and with the same, addressing the challenges of their diabetes. And so how do we bring different data sets together and recognize that a lot of the data we have in healthcare is incredibly valuable, but it needs to be linked to other data about the other determinants of health, whether it's social, environmental, or behavioral, that where you live plays a very important impact, as much as an impact as what doctor you have, even you could argue more so. So how do we bring that all together through the trust of these systems that connect, and then ultimately bring that value out of the big data, because that is a key piece. Because you can have all this big data. It's too much for any one person, one patient, or one doctor to manage. How do you bring insights from that data that can better predict, personalize, prevent those bad health outcomes, which we need as a society, and also promote a broader vision of health that's not just physical, that's mental, that's social, that's purpose, and financial?
And I'm going to take questions from the audience in 1 minute, but first, based on that, what you mentioned about the health and healthcare being kind of 2 sides of the same coin in a way, I was just wondering if you could talk a little bit about the project in Italy that you're doing with longevity.
So we've got a great partnership with Italy, and one of the areas that we want to highlight in this work is the fact that health is more than health care. And the fact that in some ways, if you think about the different communities, as I was just referencing, the acronym I like to use is health is housing, education, access to healthy choices, labor and employment, I'm using the acronym of health, transportation, and a holistic view of health that's physical, social, purpose, financial, and mental. And I mean, if you look across the globe, whether it's Italy or Japan, you've got many examples of countries that have done extraordinary work in health and have longevity. And we're very interested in potentially bringing those different data sets together to bring in a secure, private, regulatory way, and to get insights from that data through the power of Watson so we can better predict who will get sick. Like I was just at the American Diabetes Conference, and I was proud of the work we're doing with Medtronic in terms of predicting hypoglycemia. So through the power of cognitive, we were able to reduce in early stage results 65% of the hypoglycemic episodes. This is a low blood sugar, which has a huge impact, potentially a catastrophic impact on people with type 1 diabetes. So frankly, I'd like to prevent things like diabetes and arthritis and heart disease. And so how do we bring those different data sets together in a secure way, de-identified way? How do we start changing the conversation from data privacy, which is essential, to data philanthropy, where we can potentially think about ways in which data can play a role in helping us with new discoveries?
So a couple of comments, though, I think are worth adding to that. Totally agree about health and wellness, and that's really a focus of what Optum is about. It is about delivering wellness, not just health care. And in order to be able to bring that data together, it requires knowledge and understanding, and also sometimes access to information that isn't available in a lot of those data sets. In order to link them together and be sure it's the same person, you actually have to have the kind of information that patients are uncomfortable about sharing often. And so it's important not to, not to be too light, although the idea of data philanthropy is great. You have to be very sensitive to the fact that data privacy is very important. The method of linking it, making sure it's de-identified and that nobody has the opportunity to re-identify it is very important. But lastly, I think that the key message that people need to understand about technology, and we again deliver all sorts of innovative looks at networks of physicians, prediction of Alzheimer's disease, key performance indicators in opioids. Those are some of the projects we're doing at OptumLabs. But if you're just delivering an answer, that really is only a part of the way to the problem. So you have to build a process. You have to be able to go that last mile and to deliver the results in a meaningful way. You have to be able to actually reach out to the patient, bring them in, and do the intervention. And that, in any system, no matter who's creating it, that's the hardest part. Sometimes it's very easy to know, frustratingly easy to know, who are the patients that are at risk. You don't even need fancy analytics to do that. Sometimes it's just who's got an A1C, a blood pressure, and their lipids that are way too high at risk for a heart attack, for example. Can't you intervene with those patients? Well, it requires actually a system to reach out, bring the patients in, examine them, make the change, and measure that change. So you have to marry people, to take something from the Gartner group, people, process, and technology. It's not just technology alone.
Okay, great. Do we have audience questions?
Hi, I'm John Rodas, National Medical and Disability Advocate, and you're one of the main reasons I came today. My question is, you've talked about all the variabilities and things that it can do. I'm more interested in what Watson can do in the emergency room setting, because there's a lot of conditions that we have a lot of literature on, and the signs and the symptoms are there, but ERs are constantly missing them.
Yeah, so I like to emphasize after Jeopardy, which was the kind of inauguration of this era of cognitive that which is referenced by Watson, one of the first groups that came to us were doctors, because they saw what happened on Jeopardy, and they actually saw a lot of similarities to what doctors experience in terms of having a lot of information and trying to make a decision, and then seeing how Watson provided those answers in a predictive model, basically what was the ranking of those answers in Jeopardy. And so I agree in terms of the ER, having worked in those settings, that you've got a limited amount of time, you've got a lot of data in front of you, and you've got a big challenge with patients, and you don't want to miss something that could be potentially catastrophic. So, I mean, we're only 2 years old. We're very excited about the work we've done as it relates to oncology, the work we're doing in areas like diabetes, and we're very much looking to other areas as you're referencing. So thank you.
Question over here.
Hi, Edward Dow. I'm a medical oncologist, also working in consulting for pharma. My interest is, first of all, what you've been saying goes down to the famous 19th century physician Rudolf Virchow's maxim: medicine is really but social science in its purest form. And anytime you see a patient in the office, you're right, you have 15 minutes and they're out there in the rest of the world. So my question is sort of on two ends of the spectrum. As AI evolves in medicine, is there plans to also interface with neural networks? So as an oncologist, for instance, with a big interest in genomics and genetics, I see someone who's a third generation coal miner's son with this kind of demographic, these healthcare risks, and they want to know, is this tumor I have, doc, genetic? Or they say in Boston generic. But
Yeah.
And then the other issue that goes back the other way is when you're trying to put together databases, one of the problems I've run into in medical affairs support of pharma development is you can only look at claims level data most of the time, and it's very frustrating. As gentleman on the right was saying, you need to get down to patient level data. That seems to be the biggest barrier, that this privacy versus philanthropy. So that even an ER physician, when a patient walks in that ER complaining of left shoulder pain and this, that, and the other thing, history, is there an algorithm you can plug in to think of what other things am I missing in this fellow?
So the exciting thing is that artificial intelligence, we are in the era where artificial intelligence is exploding in medicine. There are many examples of it, a lot of them coming out of unusual places, many of which coming out of Stanford and UCSF and others, but some from Israel, et cetera, where artificial intelligence is being used in images to effectively identify moles as being potentially malignant, to effectively identify retinal hemorrhage in retinal images, as well as the typical retinologist, maybe not as well as the most expert ophthalmologist, but as well as that, to identify, to be able to, in typical CT scans, to identify osteoporosis to the same level that you can do with a bone scan, so you don't actually have to do, you don't have to do bone densitometry, not bone scan, but bone densitometry. So there are lots of places and in natural language processing, there are lots of efforts that are being put in terms of diagnosis, in terms of, there's something called D-Patient that came out of Mount Sinai, where they were able to reduce to 150 different variables, various aspects of patients' medical history that was able to be used then as a predictive model that was far and above anything that people have been able to generate in the past. So there's lots of opportunity. We're just at the beginning of it. Some of it will come from IBM. Lots of it will come from all sorts of places, and we're thrilled to be a part of that and be doing that.
I'm just going to attach to what Paul said. You think about medicine, you referenced the 19th century. The first stethoscope was created by Dr. René Laennec in 1816. And what I like to say is that we're in a new age of medicine where we could, through the power of cognitive, through the power of machine learning, have a big data stethoscope to help doctors basically translate all that data, hopefully into an insight, once again for augmented intelligence, where the doctor makes the decision. A big part of that big data will be the data sets that are brought together and how trust is brought across different stakeholders in health and healthcare that have typically been siloed. So you need clinical data, you need genomic data, you need social data, you need environmental data, you need behavioral data, potentially to get a real good view about people and populations. So I typically say that's 10, 20, 30, 40%. So those are the 4 key determinants of health: clinical, genomic, social, environmental, and behavioral. The last piece I want to highlight, which you were referencing earlier, is the variety of these data sets, the 4 V's of big data: the variety, the velocity of this data. Sometimes we only focus on healthcare, and each of us on average only have maybe 10 to 15 healthcare decisions we make a year, but you have to think we make hundreds of health decisions every day. So how do we sort of play a role in connecting those data sets? The veracity of that data, how we're finding with Watson for oncology is we read medical records as Watson reads it, and one part of the medical record says X and the other part says Y, and the doctor's like, so you bring it to the doctor, and the doctor says, actually, this one was wrong, this one was correct. Or claims data, fraud and abuse. There's also the volume of that data. There's almost, each of us will produce 300 million books worth of data in our careers, in our life, in our lifetime. And so that's a lot of data to put together. And then ultimately, we need the last item, which is value. Because we're in a system where, as a society, in the front lines, and I worked in underserved communities in DC and Baltimore, and saw that often at the front lines, the challenges of delivering health and healthcare. And so we've got a huge opportunity here with a big data stethoscope to leverage all this big data to deliver value and really transform how healthy our population is.
Unfortunately, sorry, we're actually, my clock here is out. Our window is too small for all the big data. But thank you so much, Paul and Q, and thank you guys all for coming. Please join me in thanking them.
Thank you.
Thanks.